Okay, good afternoon, everybody. My name is Victoria Lancy, and I'm the Rural Education Manager for the Michigan Center for Rural Health, and will be facilitating today's program. I'd just like to welcome everybody to today's Psychiatry Grand Rounds on eating disorders in athletes. We're going to go ahead and get started, just to be mindful of everybody's time. This program is provided by the Michigan Center for Rural Health in cooperation with the Department of Psychiatry at MSU and the MSU College of Nursing. Before we begin, just a couple reminders. If you are logged into the webinar portion and have computer speakers, you can listen to the audio through them. If you are listening to the program via the audio number provided, handouts are located on our website for you to follow along. Our website is www.mcrh.msu.edu. Click on the education link across the top, scroll down, find today's date, and then there you will see the presentation and attendance forms for physicians. Continuing education is available for physicians, nurses, and social workers. Please note that there is a new process for nurses and social workers. There is no attendance forms for you to fill out. Your registration was your attendance form. Your evaluation will be emailed directly to you following today's program. You must complete this evaluation online and within 2 weeks or by August 8th in order to receive your certificate. Physicians, please note, in order to obtain your certificate, you must do this through the new CME portal and fill out your sign-in sheet. The steps to do this process are located on our website. So if you have any questions, please feel free to contact me. If you would like to ask a question during the program, please type it into the chat box so you don't forget it, and we can address it during the Q&A component at the end of the program, or you can ask it directly to the presenter during the Q&A program when I unmute all the lines. Our presenter today indicates no conflict of interest, and the planning committee did not have any conflicts. There is no commercial support for this program, and with that, I am pleased to introduce our speaker, Dr. Samantha Kennedy, who is an assistant professor with the Department of Psychiatry here at Michigan State University.
All right, so I'll start with my disclaimer that I might be a little tired, and if I get confused, bear with me because someone decided to come 5 weeks early, so I wasn't anticipating having a baby at this point. So haven't slept the greatest in the past week, so just bear with me if I sound tired or get things kind of backwards. All right, so some learning objectives. Learn how to identify eating disorders in male and female athletes, and the general principles of treatment of eating disorders in athletes. It can be more difficult to identify eating disorders in athletes than in the general population, but with how early children and adolescents are now becoming involved in competitive sports, it's really important to be able to identify eating disorders in athletes. So we'll go over the general principles of treatment in athletes as well as in the general population, and some unique features for treating eating disorders in athletes. So first, how did I get into this field? I played soccer all my life and eventually played in college and semi-pro. Eating disorders were relatively rare in soccer when I played because emphasis was on strength and speed. And then after the end of my soccer career, I transitioned to professional triathlon, where I quickly discovered eating disorders were sadly common, especially among the professional women. Triathlon is composed of 3 sports, swimming, biking, and running, and the emphasis in all 3 sports is on endurance. Eating disorders are more common in endurance sports, so I encountered many more athletes with eating disorders when I began competing in triathlon. Watching teammates and fellow competitors struggle with eating disorders really motivated me to learn more about eating disorders in athletes and the differences of this illness in the athletic population versus the general population. So some statistics in the general population: for women, less than 1% for anorexia nervosa, 1 to 2% for bulimia nervosa, and 3 to 5% for partial syndromes. Statistics on men are not really available or very accurate, but the prevalence is estimated to be lower, but that may be in part due to underreporting. In athletes, the overall prevalence is higher than in the general population and even higher in female athletes and sports that emphasize leanness. which include endurance sports such as running, aesthetic sports such as gymnastics. There's been a big variation in the estimates of prevalence of disordered eating and eating disorders in athletes, but it has been clear that they're at higher risk. And the variation is due to differences in competitive level, sport type, and the method used in the research studies to try to evaluate and come up with estimates. So the diagnostic criteria, the DSM-5, the Diagnostic and Statistical Manual of Mental Illness, our 5th edition, is used to define eating disorders in my field. The big change between the previous version, which was the DSM-4-TR, and the current version is that amenorrhea is no longer a criteria for anorexia, and that acknowledges that eating disorders occur in men as well as women. And again, it's really difficult to get an estimate because there's a lot of underreporting in eating disorders in general. So the diagnostic criteria for anorexia, it's a restriction of energy relative to requirements, leading to a significantly low body weight in the context of age, sex, developmental trajectory, and physical health. Significantly low weight is defined as a weight that is less than minimally normal, or for children and adolescents, less than that minimally expected. It's a mouthful of wording, but basically the first criteria is getting at that there is no universal weight that is considered underweight. Rather, you have to look at each person individually and find out what should a healthy weight for this individual be and how far below that healthy weight is this individual. The wording minimally expected, used for children and adolescents, means we're looking at the growth curve, and is the child or adolescent's weight where it should be, or is it significantly below the curve that the individual child or adolescent should be on? The second part is the intense fear of gaining weight or of becoming fat, or persistent behavior that interferes with weight gain even though at a significantly low weight. So even though the individual is underweight, they can't see themselves as underweight and continue to see themselves as fat. So they continue to engage in those behaviors to lose weight or prevent weight gain. It's basically saying they have no insight into the illness. The third criteria is the disturbance in the way in which one's body weight or shape is experienced, undue influence of body weight or shape on self-evaluation, or persistent lack of recognition of the seriousness of the current low body weight. The second part of that third criteria is the one that can be shocking. It's that undue influence of body weight or shape on self-evaluation. So typically your anorexic patients are perfectionists, and they will have perfect grades, they'll be involved in a lot of different activities, and they'll generally be really successful, but they won't care about any of that and will only care about weight. And they'll continue to think that they are a failure because they're fat. And at some point, their other activities will begin to suffer, but they'll just continue to focus on weight. And that part can be really frustrating and difficult to understand for parents. So it's kind of divided into two different types: the restricting type, the binge eating purging type. A lot of times it's kind of a combination of the two. Lifetime prevalence statistics, again, 0.9% for women, 0.3% for men. Typically develops between the ages of 12 and 13, which is often when puberty occurs. And that can be especially difficult for girls as they gain weight, they gain adipose tissue. We'll go over this more later, but it can be really difficult for athletes, especially in sports where leanness is emphasized, like running and gymnastics, because that normal weight gain, the adipose tissue, can cause a decrease in performance, and that can be really difficult for these young athletes when they've spent years and years in that sport already. And anorexia has the highest mortality rate of all psychiatric illnesses, 0.56% per year mortality in young women, which is 12-fold higher than in the general population. Some signs of anorexia: emaciation, so you'll get the prominent collarbones, ribs will be visible, spinous process in their back will be visible. The more obvious sign in adults is weight loss, but in children and adolescents, what you'll see is an altered growth curve where they will fall off the curve that they had been on before. Menstrual disturbance, inconsistent or complete cessation of menses. And you get lanugo, it's the soft, downy body hair, with brittle hair and nails, and then hair loss or thinning on the scalp. Just some pictures. On the bottom middle is the picture of lanugo. It's the soft, fine hair that's normal when you see it on a newborn, but it begins to appear on patients with malnutrition. And then on the right is an example of an adolescent falling off his or her growth curve. You see the height curve flattens. Well, they've completely fallen off the growth curve and gone completely, well, they're completely off the chart. Bulimia nervosa, the diagnostic criteria, recurrent episodes of binge eating. An episode of binge eating is characterized by both of the following. So eating in a discrete period of time, an amount of food that's definitely larger than what most individuals would eat in a similar period of time, a sense of lack of control over eating during the episode, and the feeling that one can't stop eating. And so when they say larger amounts of food, the very large number of calories, and sometimes it can be more than the individual's caloric requirement for the entire day, and it's eaten in a short period of time. And a lot of times, because of these recurrent episodes of binge eating where they're eating so many calories, individuals with bulimia are often normal weight or even overweight. And we see so the second criteria is the recurrent inappropriate compensatory behaviors in order to prevent weight gain, such as self-induced vomiting, misuse of laxatives, diuretics, other medications, fasting, or excessive exercise. And binge eating and inappropriate behaviors occur on average at least once a week for 3 months. And then again, self-evaluation unduly influenced by body shape and weight. So with those binge eating episodes in bulimia, that typically happens because the individual is trying to go completely without food, but then they become hungry and that overwhelms them, and so they begin to eat and can't stop. And that's a big target for treatment for bulimia. You can schedule meals and snacks, so taking away that starvation and the overwhelming hunger, and you can hopefully prevent those binge episodes. And then the excessive exercise compensatory behavior is an important one to keep in mind for athletes. So you'll see athletes who are training outside of already rigorous team practice schedules. So for example, most high school teams practice 5 days a week, and you might see an athlete who is training after weekday practices or even on weekends when they're supposed to be having rest days. Bulimia demographics, lifetime prevalence in women, 1.5%, 0.5% in men. Signs of bulimia are salivary gland hypertrophy resulting in a chipmunk appearance, and that's caused by the repetitive vomiting, erosion of dental enamel by stomach acid from vomiting, calluses on the back of the dominant hand, the Russell sign, again from vomiting, and mouth ulcers. And so these signs are mostly the result of vomiting. So in patients with bulimia who don't engage in vomiting, such as your athletes who are exercising excessively, it can be more difficult to identify because you won't have kind of these obvious signs. This is what some of the signs look like. You can see the erosion of the enamel on the top left, the chipmunk cheeks on the top right, calluses on the hand in the bottom left, and mouth ulcers on the bottom right. And a lot of these signs are in the mouth and on the teeth, so this is often found by dentists. And then also to note, the enlarged salivary glands often don't go back down with remission of symptoms and will stay enlarged, so that continues to be a problem and one of those self-evaluation issues for patients with bulimia. Other specified feeding or eating disorders, atypical anorexia nervosa is one of them. So all the criteria for anorexia nervosa are met, except that despite significant weight loss, the individual's weight is within or above the normal range. And then a bulimia nervosa with a lower frequency and not limited duration, so you haven't hit 3 months yet. In particular, I've seen a recent increase in the number of cases of atypical anorexia nervosa. And in my practice, I've seen that when children and adolescents who were previously obese have lost a significant amount of weight. And so now they're normal weight, they have all the other diagnostic criteria of anorexia. And I think that given enough time, those patients would eventually meet the weight criteria for anorexia. But we have an opportunity here to step in and begin treatment before the child or adolescent becomes significantly underweight, and so then you can prevent the medical consequences that come from being significantly underweight. And then unspecified feeding or eating disorders, formerly known as eating disorders, not otherwise specified. This is the big catch-all category where, clearly there's something going on that's causing distress or impairment in function, but it doesn't meet the criteria yet for anything else. All right, some medical complications of eating disorders. Cardiovascular, you'll see bradycardia. You might see a heart rate that's in the 30s, and that can be even lower at night when they're sleeping. Dizziness because of low blood pressure. Sudden cardiac death, that's the big one. That's the most common medical cause of death in patients with eating disorders. And cardiac arrhythmias, that's a dangerous complication in bulimia due to the electrolyte disturbance caused by vomiting. GI, decreased motility of the intestines resulting in constipation. Tears of the esophagus can occur in bulimia nervosa because of the repetitive vomiting. Endocrine, you can see infertility, but keep in mind that patients with eating disorders can still become pregnant. So you do have to check for this because any fetus would be at very high risk. Decreased function of the thyroid and osteoporosis. So in adolescent patients, that can result in a permanent stunting of growth. So as you all know, adolescents have that certain window to accumulate bone density. And unfortunately, eating disorders typically occur during that critical period. And also, unfortunately, in my clinical practice, I found the vast majority of adolescents do not care. If they have a worrisome bone scan that indicates that they are at risk for osteopenia or osteoporosis later in life, it's just too far down the road for them to even consider, and they're too focused on the belief that they are fat right now. Some renal complications, kidney stones, and then refeeding syndrome. It's very dangerous. When feeding starts, insulin triggers the uptake of phosphate from an already depleted system. And the depleted sources of ATP, which are dependent on phosphate in the myocardium, results in tissue hypoxia. And then you get cardiorespiratory dysfunction or failure, which is why patients who are severely underweight need to undergo refeeding in an inpatient setting. So checking labs on an eating disorder patient is an important part of monitoring, but it's important to keep in mind that anorexic patients and patients with bulimia nervosa live in a pretty fragile balance, and labs can look largely normal one day, and then suddenly the body can't maintain that balance anymore, and labs can become grossly abnormal. So although labs are very important, it's still important to counsel patients that a normal lab result doesn't mean that they're safe and that nothing bad will happen. All right, eating disorders in athletes. So eating disorders occur more frequently among athletes than the general population. Like I said earlier, the estimates vary greatly from study to study because the studies just aren't consistent about the athlete type and the sport. The estimates vary from 10 to 20% or even more. And then you have disordered eating, which is a broad spectrum. For athletes, it typically starts with healthy dieting that can progress to more restrictive weight control or an increase in exercise. And those unhealthy habits may be reinforced by fellow athletes, coaches, or even a brief improvement in performance, which can lead to a full-blown eating disorder. Many studies that have shown this increased risk for disordered eating in athletes have been conducted in elite athletes. There have been a few studies done in recreational athletes or college club athletes that also show a higher prevalence than in the general population. So your weekend warrior athletes, or even the adolescents who are just maybe doing it for fun, are also at risk. There was a study of Norwegian elite athletes that found 20% of the female athletes and 8% of the male athletes met criteria for eating disorders. And like I said, that there's been additional research that shows even independent exercisers and club athletes endorsed more body satisfaction than non-athletes, so kind of setting them up at being at risk. Let's see. Oh, on the next one, I was going to get a new statistic. That's the one that I just talked about. And then, like I said earlier, the prevalence is higher in sports that emphasize leanness. That would be one of those statistics that I was planning to replace, but then baby came along and I didn't quite get to that. So another study was the NCAA study on eating disorders in athletes. It was a study of 1,445 student athletes from 11 Division I schools. Among the female athletes, the mean desired body fat was 13%, and the mean actual body fat was 15.4%. Keep in mind that healthy body fat for women is 17 to 25%. And 173 of the female participants had a BMI considered underweight. Among male athletes, The mean desired body fat was 8.6%, and the mean actual body fat was 10.5%. And again, the healthy body fat for men was higher than that at 10 to 15%. 9.2% of the female athletes and 0.1% of the male athletes had bulimia nervosa, and 2.85% of the female athletes had anorexia nervosa. So the female athlete triad is something a little bit separate, but that's important to talk about and keep in mind. It's a combination of amenorrhea, osteoporosis or osteopenia, and disordered eating. So the female athlete triad does not necessarily mean that there's an eating disorder going on. The disordered eating may be due to lack of nutritional information, and so the athlete just isn't aware of how many calories they need, and that can be helped with education. This is especially common, the scenario is especially common in freshman athletes because they may not be used to choosing their own food or snacks for the first time, and they're not sure how to properly fuel for the increase in training volume that you see when athletes transition from high school to college sports. They typically go from training maybe 4 to 5 days a week for a couple hours in high school to training 5 to 6 or even 7 days a week in college, where the training is typically more intense. And typically, the vast majority of college sports have a preseason that lasts maybe a couple weeks, and athletes can be training 2 to 3 times a day, and they might never have done that before. And so most freshmen just don't know how to properly fuel for that increase in activity. Okay, so why are athletes at increased risk? One of the big ones is sport-specific body ideals. So athletes are under a lot of pressure to conform to an ideal sport-specific body type. And athletes who do not fit the ideal body type for their sport are more likely to experience pressure both from the athlete themselves or from others to achieve the sport-specific body ideal, which can predispose them to body image dissatisfaction. And then it's generally accepted among athletes and coaches that thinness will result in improved performance, although that's not true. But unfortunately, especially in endurance sports, that will be initially true. Runners who lose weight will initially have better times, but as their health deteriorates, their times will become worse and worse. And unfortunately, when the running times become worse, instead of thinking they need to regain weight and health, the runners typically feel they need to continue to lose weight and they will become fast again. And then some sports that reward or require low weight may have even more pressure, like lightweight rowing or wrestling, where they're trying to get into a specific weight class. Certain sports are considered high risk for eating disorders, so aesthetic sports such as gymnastics and figure skating due to the importance of appearance and judging. Weight class sports, like I just mentioned, like wrestling, where athletes will try to be at the lowest weight possible with the most amount of strength possible. Then endurance sports such as cross country and distance events and track, where there's that belief that thinness improves performance. Uniforms. Uniforms are a big one. They're the hallmark of a team, but they can add pressure to conform to a certain body type. Athletes may feel pressure to fit into the same uniform type as their teammates, even if it's not a good fit for that athlete's body type. Most uniforms are very tight and form-fitted, which can make athletes even more self-conscious about appearance. So one important example, I think, is in women's running. So there's different types of women's running bottoms. There's the bottom that most recreational runners wear, which is your typical running short. That's the top left. Then there's the tighter fitting spandex shorts, which are not quite as forgiving as the running shorts, not that they're all that forgiving to begin with. And then finally, there's the bikini bottom, which is the bottom that you see in the bottom picture. It's the most common bottom type worn by college cross-country teams and track athletes. And so female athletes may feel pressure to wear the same bottoms as the rest of their team, despite not feeling comfortable in those bottoms, or maybe they're just not a good fit for that athlete's body type. Then personality characteristics, that's another big one. The personality of athletes may also result in increased risk for the development of eating disorders, especially elite athletes. Your athletes tend to be perfectionistic, goal-oriented, competitive, and concerned with the outcome of performances. So although these characteristics tend to result in success for the athletes, they're also the same characteristics that have been repeatedly seen in individuals with eating disorders, especially anorexia. Additionally, athletes are also very disciplined, and they can stick to a restrictive diet, and they have a high pain tolerance, and so they can withstand the discomfort and pains of starvation because they're used to withstanding the pain of constant training. And many athletes continue to train through injuries, especially more minor injuries, so they have a higher level of tolerance for pain and discomfort. Next is the timing of athletic competition. Most athletes, in order to be successful, must be competitive from a pretty young age. So this makes the body changes of puberty more difficult for athletes, especially if the body changes have an impact on performance. That's very commonly seen in female gymnasts, where the gain of adipose tissues around the hips can change their center of gravity. So in a sport where perfect balance is required to successfully complete the different tricks and moves, it's going to be really upsetting, and these skills that athletes have previously mastered may need to be relearned. And this process typically occurs at a time when gymnasts must have mastery of high-level skills in order to be successful, like if they're trying to make the Olympic trials. And most competition takes place during adolescence, athletic competition, which is typically the onset of eating disorders. And then you can also have competitive parents who may push their child to achieve in a certain sport even when the child has lost interest in that sport, and that can cause problems as well. Age, so where do athletes play after college? Although there are opportunities in football, baseball, hockey, and basketball, there are very few other professional sports where athletes can make a living. Track and field, for example, approximately 50% of our athletes who rank in the top 10 in the U.S. in their event make less than $15,000 annually from the sport through a combination of sponsorships, grants, prize money. And many Major League Soccer players make as little as $50,000 a year. And this is most evident in gymnastics, where the typical age of retirement is before 20 years or young 20s. So this shorter lifespan or shortened career of an athlete increases the pressure to perform at a high level from a young age, especially during that critical time in development. So when athletes are going through puberty, this is commonly when colleges are beginning to recruit high-level athletes. So they really need to be at the top of their sport, and that can be disrupted by puberty. Coaches. So coaches can have a very significant impact on the life of an athlete, whether for good or bad. They're a major source of influence for athletes and may pressure athletes to maintain or achieve lower weights, or coaches may purposefully ignore symptoms of disordered eating because of that false belief that decreased weight will improve performance. Multiple previous research studies have shown that being told to lose weight by a coach was found to be a risk factor for the development of eating disorders in female athletes. Athletes may feel pressure from coaches or others to achieve lower weights, and the coaches may not be sensitive to weight-related issues among female or male athletes and make comments about weight and performance, which can further confirm the belief for an athlete that leanness is better. Eating disorders in male athletes. So some differences between eating disorders in men and eating disorders in female athletes. So like I've said, the estimates of eating disorders in male athletes are likely low, and it can be difficult to identify eating disorders in male athletes. And the sport-specific body type ideal in men tends to be lean but also muscular. And this can result in risky behaviors to achieve that body type ideal, such as anabolic steroid abuse. Eating disorders are also more common among male-dominated sports that require strict weight control, like wrestling. But it is difficult to identify male athletes with eating disorders, and so it's more difficult to treat. Also, weight fluctuation can increase the risk for the development of an eating disorder. So the big decreases in weight can only be achieved by a strict diet restriction, which can result in a pattern of unhealthy restriction beyond the sport. Consequences of eating disorders specific to athletes. So eating disorders in athletes can have serious medical consequences, such as impaired muscle and skeletal health due to low energy availability. And athletes are at increased risk for these consequences because of the increased demands on them from training and competition. And athletes with eating disorders may require more time to recover from injuries versus healthy athletes. Eating disorders can have a significant impact on athletic performance, including reduced sport performance due to dehydration or fatigue, and increased risk for injury. So early identification is really important to reduce the risk of further injuries or to reduce the risk of more catastrophic injuries that could be career-ending. How to identify eating disorders in athletes? It can be difficult to identify eating disorders in athletes because athletes training to improve performance may have characteristics that overlap with disordered eating behaviors, but may not necessarily be pathological. For example, athletes will frequently train long hours to prepare for big events, but not with the intent to lose weight. And additionally, athletes may need to count calories in order to assure adequate nutritional intake, but they might not have the intent to restrict their intake and to lose weight. So some signs of eating disorders in athletes: frequent injuries or season-ending injuries. So, for example, pulled muscles that take longer than usual to recover from, and stress fractures. Because decreased intake can leave an athlete weaker and more susceptible to injury. And frequent injuries or major injuries may be a sign of adequate nutritional intake. But keep in mind that stress fractures may not be abnormal, but they could be a sign of poor intake, leading to issues with bone and bone healing. So that, again, that weight loss or drop off the curve in adolescence, but it can be normal for athletes to have slight fluctuations in weight, including gaining weight during the off season and losing weight during the competition season. But big changes in weight for adults or cessation of growth in adolescents may be signs of pathogenic behavior. Recent increase in athletic activity without an upcoming A competition, so the big focus competition. In high school athletes or club athletes, that might include that they're doing additional training outside of practice. So if you see that athletic activity has increased dramatically, but they're not training for something specific, they don't have, states or nationals or regionals, whatever it may be coming up, this could be a pathogenic behavior. And then a decrease in performance. Athletes may complain that their performance has decreased, and they may be looking for a medical explanation, such as low iron or something else going on. And basically they're looking for any reason for their decrease in performance other than inadequate intake. Following a specific diet to improve performance. The type of diet can also be a sign. So, for example, the majority of athletes would not need to follow a low-carb diet, whereas a high-protein diet might be normal. So asking an athlete if they're following a specific diet for the purpose of improving performance, that can seem less threatening to them. And if the athlete describes a very rigorous and specific diet, that may be an indication of a pathogenic behavior. Avoidance of rest days is another one. It is pretty common for athletes to be uncomfortable with rest days. So the important question to ask is why? Do they worry about weight gain if they're not training daily? Or does the athlete just prefer to train daily but understands the need to let the body rest? Unhappiness with their performance weight. Are they actively trying to lose weight? How much weight are they trying to lose? So again, that wording, performance weight, can be less threatening to an athlete with an eating disorder than just asking about their weight. You can ask what their goal performance weight is, and if this weight is much lower than the athlete's current weight, such as 15 pounds or more, then that may indicate a pathogenic behavior. Use of diet pills, laxatives, diuretics, caffeine. Caffeine use can be extremely normal in athletes. So it's kind of looking at the timing. Are they using the caffeine before competitions to try to give themselves that boost, or is it something that they're doing every day? And then irregular periods. But in female athletes, periods can be irregular, and that can be normal. So that's, again, just one possible symptom, and you need to see other symptoms. So some special considerations for male athletes include a preoccupation with muscular development, anabolic steroid use, frequent weight fluctuations, which can be seen in wrestling, rowing, and bodybuilding. Preoccupation with a power to weight ratio, so again, that's being as strong as possible but weighing as little as possible, and then binge eating for muscle or weight gain. And especially in male athletes, it's important to keep in mind that larger athletes who are categorized as obese due to their BMI can also have eating disorders. That's especially true in football players. There are certain positions in football that are expected to be very large and muscular but also very fast. That's a difficult balance to achieve, and that can result in pathogenic behaviors as well. So the bottom line, in the athlete, many of these signs alone are not enough because many of them could be normal. But if multiple signs are present, that should raise a suspicion for an eating disorder. Or if you just get the feeling that these behaviors that they have are really starting to impair their function or kind of taking over their thoughts. It's something that they're focused on weight all the time. So what to do about it? Prevention is the big one first. Educate athletes on the dangers of low body weight, and that leanness does not result in improved performance. Initial weight loss can result in improved performance for athletes. And again, that adds to that belief that the leaner the athlete can get, the better, but it's that continued weight loss and deterioration of health where performance will really decrease. Promote total health that does not focus on weight, as it's a poor indicator of overall health, especially in athletes who may be heavier due to muscle mass. If at all possible, eliminate public or team weigh-ins, and then eliminate careless remarks or ridiculing athletes regarding weight. Screening. So the American College of Sports Medicine and the International Olympic Committee have released statements supporting the regular screening for disordered eating in athletes. And early detection of disordered eating through screening can prevent progression to full-blown eating disorders by utilizing interventions in education. So, screening tools. There are currently screening tools available, but most of the tools were created for female athletes or elite athletes only, and there is no current screening tool that can be used in both male and female athletes of all ages, all sports, and all levels of competition. The bottom line, currently there is no universally accepted screening tool for eating disorders or disordered eating in athletes. There are some commonly used screening tools. These are used in the general population. There's the EAT 26, which is the Eating Attitudes Test. 26 is 26 questions long. The Eating Disorder Examination Questionnaire, the Eating Disorder Inventory, and then the Child Eating Attitudes Test. But it's unknown how accurate these screening tools are in athletes, and none of these tools have been studied very extensively in athletes. So your medical evaluation. First, most important, identify if the patient requires immediate hospitalization and stabilization. So are the vital signs dangerously abnormal? Are they refusing to eat anything at all? So check your vital signs, including weight, height, blood pressure, and pulse, and calculate your BMI. And if they complain of dizziness on standing, then you can check orthostatic blood pressure as well. When checking weight, keep in mind that many anorexic patients will wear extra clothing or they'll hide heavy items in their pockets. So I like to establish a certain outfit type that the patient agrees to wear every time they come see me, such as loose shorts and a t-shirt. So they can wear baggy sweatpants or a sweatshirt on top, but they have to be weighed in similar garments without shoes. And you might need to have an attendant present during weigh-ins if they're having to take off clothes. And then I always have patients face away from the scale so they don't know their weight. Some labs, urinalysis, CBC, CMP, amylase, lipase, phosphorus, magnesium, thyroid function tests. Get an EKG if the patient is complaining of chest pain. Bone density, that test isn't really urgent, but you should get that completed at some point for female patients who have had amenorrhea for 3 months or greater. There's not really a specific recommendation for males, but it'd probably be a good idea if they've maintained an unhealthy weight for 3 months or greater. So you've screened your athlete patient through a combination of the screening, vital signs, history, and you determine they have an eating disorder. So now what? So where do they go? Outpatient therapy is the lowest level of care, and you can only use this option when patients are medically stable. If an athlete with an eating disorder is being treated outpatient, they'll likely need a team of providers, at least in the early stages. So a registered dietitian, a therapist or a psychologist, pediatrician or a primary care physician, and then maybe you need a psychiatrist. Research has not found that any medication is effective in treating anorexia. So if the athlete has a pre-existing psychiatric condition such as anxiety, depression, OCD, then psychiatric medication may be beneficial, and that's a good time to get a psychiatrist involved. In clinical practice, athletes typically respond well to psychotherapy, especially if they're identified early. Because keep in mind with athletes, their main goal is performance. So a therapist can help the athlete to realize that the eating disorder is actually causing them to be weaker and performance to decrease as opposed to improving performance. Next is partial hospitalization programs. So they go to these programs during the day for treatment sessions, but then go home at night. The University of Michigan has a partial program. Their program can be a big time commitment though for the family because they require the involvement of the family, but that is an important component of treatment is to get family involved. Next level is residential. That's when the patient lives at the facility and attends treatment sessions with therapists, nutritionists, and a psychiatrist during the day. It's typically not covered by insurance or only partially covered by insurance. And some of those places can cost $10,000 to $30,000 a month, and the average stay can be somewhere around 3 months. And there is no residential treatment program in Michigan. Inpatient hospitalization, that's when they're medically compromised and they need medical treatment for stabilization. So you have to use this setting when severely underweight patients are refusing to eat and they need to be force-fed by feeding tubes. But there are some residential programs that have kind of their version of an ICU where they can care for medically unstable patients and they can use feeding tubes if they need them. This is a pretty busy slide, so I won't go over the whole slide, but these are the American Academy of Pediatrics criteria for inpatient hospitalization of eating disorders. The criteria for anorexia nervosa are mostly vital signs, and then, of course, a refusal to eat. For bulimia nervosa, the big danger is those electrolyte imbalances. And, of course, for both is the failure to respond to outpatient treatment. So medications, like I said earlier, studies have shown only limited benefit of medications in the treatment of anorexia. Antidepressants, including selective serotonin reuptake inhibitors, may help with symptoms of depression and suicidal ideation in patients with anorexia, but they have not proved beneficial in weight restoration or in preventing relapse. So we don't get a lot of help with medications in the treatment of eating disorders, and the role of medications is more to treat disorders that are comorbid and maybe contributing to the eating disorder. In patients with underweight BMIs, SSRIs probably aren't going to be very effective anyway because they have decreased serotonin production due to the malnutrition. So even if you inhibit the uptake of serotonin, we don't know how effective or helpful that will be. So there have been case reports and preliminary studies that have suggested a role for atypical antipsychotics like Zyprexa, but controlled studies have not demonstrated significant benefit in patients with anorexia nervosa. In my practice, I've found that atypical antipsychotics like Zyprexa can be helpful for causing weight gain, but they don't have much of an effect on the cognitive distortions that are the key driving force of eating disorders. Additionally, you have to be really careful because anorexic patients don't want to gain weight, so they may restrict even more to offset the typical weight gain caused by a medication like Zyprexa. Or they may feel even worse about themselves with regards to eating, so that could cause additional problems after the medication has stopped because they don't like that feeling of being out of control. In patients with bulimia nervosa, studies have suggested SSRIs may be beneficial in decreasing the frequency of binge eating and purging. So the addition of an SSRI might be considered for patients who are not responding to an initial trial of psychotherapy and for patients with major depression or some other comorbid disorder that is responsive to antidepressants. And with all eating disorders, you never want to start Wellbutrin. Wellbutrin can cause weight loss, so that's not helpful. And additionally, it lowers the seizure threshold, and so it can be really dangerous in patients with bulimia nervosa. All right, that's all I have. So questions?
Okay, so please feel free to type your questions into the chat feature if you have any questions, and then I will also be unmuting some of the lines for questions. So I will be unmuting all the telephone lines, so please be, oh, we have a question here first. It says, is there a term or DX for people who report that they can only eat or keep one particular food? Like people who hear about who can only eat French fries or pizza, etc., or a diagnosis?
That would probably might fall under one of the other restrictive intake disorders. It's in the same feeding and eating disorders category in the DSM-5. I don't know that it would meet all the criteria for that, so it might just fall under that not otherwise specified or unspecified eating and feeding disorder. I can't tell you right off the top of my head.
Okay. Are there any other questions or comments? So,
I don't know if you can hear me, but I do have a question.
go ahead. You're unmuted.
I don't understand the part of what is the cause of the calluses on the back of the dominant hand with the bulimia? Is it that the hand rubs against the teeth and they do that much that it causes that injury, or is it a deficiency that just runs through that side of the body?
Are you talking? I was having a little trouble hearing. Are you talking about the calluses on the back of the hand?
Yes.
Yes.
Yep. Okay, those are from the acid from vomiting. So the acid that gets.
Oh, okay. Well, that explains that.
Yeah.
Thank you.
Yep.
Do we have any other questions or comments?
She's always been thin. Then she came on. So yeah, but I wasn't like, I didn't want to have to enter into a contract with them. For sure, with meds, they have a whole med
Do we have any other questions or comments? Oh, it says we have another question. It says thank you, good information. Any other questions or comments? Okay, if nobody has, or if you think of a question or comment later, or if you can't think of one now, you can indicate it on your evaluation, or you can email it to me and I can pass it along to our speaker. But we'll go ahead, and nobody has any other questions or comments, we'll go ahead and sign up, and we won't take any more of our speaker's time, and then we won't take any more of your guys' time. And thank you everybody for joining us, and have a great day.